Hi and welcome. I'm Dr. Robert Glatter, medical advisor for Medscape Emergency Medicine. The well-established standard treatment for acute appendicitis is surgical appendectomy. I think we can all agree on that. It's pretty clear. However, there's a lot of research recently in the past decades that's challenged the dominance of the surgical approach, looking at using antibiotics alone. And many of us are well aware of this. The literature we're talking about is really limited by important things, and we should talk about these, such as exclusion of patients with appendicitis, a very small sample size, and also the predominance of using an open approach versus a laparoscopic approach. And certainly the data is interesting, the studies are interesting, but we really need more data on this. And this is what CODA did, the comparison of outcomes of antibiotic drugs in appendectomy. The New England Journal study that was published in November of 2020 that compared antibiotics with appendectomy. And the question they were asking was, in adult patients, are antibiotics non-inferior to surgery for treatment of acute appendicitis? Here to join me in this really important discussion is Dr. Joseph Sakharin, an acute care and trauma surgeon at Johns Hopkins Hospital, and Dr. Ali Raja, Executive Vice Chair of Emergency Medicine at Massachusetts General Hospital, Harvard Medical School. Welcome, gentlemen.
Thanks so much for having us.
Yeah, hey Rob.
Yeah, it's great to have you. And this is such an important discussion to have, obviously for all emergency physicians, general surgeons, internists, you name it. We're all interested in this, especially with the pandemic hitting. So how do we manage these patients that are rolling in the midst of COVID? So Ali, I was hoping to start with you, if you could just sort of describe what CODA was, the study design, and what it was looking at, the outcomes, and we'll start off with that.
Yeah, that sounds great. And then I'll hand it off to Joe to talk about the rest of it. But CODA, so first of all, sometimes these studies have horrible acronyms and names, but this one actually makes sense. With CODA, it's the comparison of outcomes of antibiotic drugs in appendectomy. It actually is a perfect title because that's exactly what they did. And so it was a pragmatic, non-blinded, non-inferiority randomized trial. And what that means is, it's hard to blind somebody to getting an appendectomy versus getting antibiotics, but obviously this needed to be non-blinded. And the main thing that they wanted to do was, Rob, as you mentioned, the standard really has been getting appendectomies. And so they didn't need to show, this study was not designed to show that one was necessarily better than the other, but the goal was actually to show that antibiotics were non-inferior. And then the randomized bit, obviously, they just randomized. And it was done at 25 different centers across the US. What the two treatment options were either surgery, laparoscopic, or conventional. But I think in their study, like 95, 96% of the surgeries were actually done laparoscopically, which is different than many of the prior studies, versus antibiotics. There was at least 24 hours of IV antibiotics followed by 10 days of oral antibiotics after that. And then in terms of outcomes, they looked at a couple of things. The first is that they focused on this thing, a 30-day health assessment, and they used something called the European Quality of Life, which has 5 dimensions. And I always have to look this up, so I wrote it down, but basically it focuses on 5 things. It focuses on mobility, self-care, usual activities, whatever those usual activities are, pain and discomfort, and anxiety and depression, and scores range from 0 to 1 overall. And then secondarily, they looked at all the stuff we would want them to look at. Did the patients who got the antibiotics end up needing appendectomies later on? Did the patient's symptoms actually get better, and complications and serious adverse events? So that's what the trial was about, and those are the outcomes they were looking at.
So obviously this is a pretty subjective measure, would you say? I mean, certainly,
it really is. How well you're doing your daily activities, how anxious you are. There's a lot of subjectivity built into this, yeah.
And certainly it's an unblinded study for that reason. And trying to look at that factor subjectively, and someone who's had their appendix out versus not, is quite difficult to do. And there's some, issues, as a person, as a surgeon assesses them. But I think the study was admirable in that sense. And I understood why they picked this factor to analyze patients.
Yeah, I mean, if I can just build off of what Dr. Raja gave such a nice kind of overview, and I think, sometimes we're hearing a lot, over the past decade of these non-inferiority trials. And I think, just to kind of make it very simple, these trials are essentially an attempt to show that the new treatment, which in this case, is the antibiotics, is not an unacceptably worse alternative to the standard, which is, typically still operative intervention. And, when you look at this primary outcome, this 30-day, assessment using EQ5D, the eQual that Dr. Raja just described, I mean, it's very interesting because there is a lot of work right now trying to look at what happens when patients are discharged out of the hospital. In general, we don't do, as a system, don't do a really great job about understanding the long-term outcomes or the post-discharge outcomes. And so looking at this in a patient-reported outcome measure is actually very interesting. I will say, part of me wondered whether that was the right primary outcome to be evaluating. When you look at some of the secondary outcomes they included in this study, included appendectomy in the antibiotic group and complications through 90 days. And so, we don't have anything past 90 days, but it was up until 90 days.
One thing that struck me is that if you're going to stay in the hospital one day and get IV antibiotics, wouldn't you just want your appendix out? I know the surgeons wanted to see if you became peritoneal, certainly. That was a reason, in terms of their study design. But in my standpoint, I would just like to get the antibiotics, even oral ones, you watch for a few hours and go home. So, in that aspect, it was a little interesting. I don't know what both of your take on this is.
So Dr. Glatter, just before Dr. Sacker talks about the outcomes of the study and everything else, it was fascinating to me that because of the fact that while this was a fascinating and well-designed study, only 30% of eligible patients agreed to undergo randomization. So just like you're thinking, if they heard, oh, well, I'm consenting to this trial, the two arms are, I get my appendix taken out tonight or tomorrow, or I stay in the hospital for IV antibiotics for a night anyway. Well, I wasn't planning to have appendicitis. My schedule is ruined. I don't want to be in the hospital. If one of the options is going home right now on oral antibiotics, maybe I'll do that. But if both options require me to stay in the hospital for a day or two anyway, well, why do I want to do this study? Just take my appendix out. And 70% of patients agreed or didn't want to actually undergo randomization and go into the study. And that's probably because of exactly what you just said.
Right. I think people expect to have their appendix out. This is something that the community, the world knows that if you have appendicitis, traditionally, this is what we do. So convincing people, that public perception, that shared decision-making is so important as our studies go forward.
Yeah, I think that's right. And just to build a little bit off what both you and Dr. Raja have been articulating around, this kind of, one-day admission, what happens next, the self-selection that occurs and only those 30% actually agreeing to undergo randomization. If you look at the careful wording in regards to the initial kind of antibiotic course, which was IV antibiotics for 24 hours or bioavailability. And when you look at, there was 47% of the antibiotic group which were not hospitalized for the index treatment. So what that means to me is either they got something like ertapenem, right, in during the initial ED visit, which lasts 24 hours, or they maintained their time in the emergency department and then were sent out of the emergency department. And I'm sure Dr. Raja has a lot of thoughts about this, but I can just say, as we focus on continuing to rapidly move patients out of the ED as a metric in many institutes, it would be interesting to hear about the feasibility of that if folks were not going to use something that had a 24-hour bioavailability. I also think that when you look at, this study is very different in the sense that this was really the first time that we had a study, unlike the European studies, that the predominant intervention was a laparoscopic appendectomy. I think Dr. Raja said in 96% of the cases. And that's important for a variety of reasons. I can just give you my own personal example. A lot of my patients with uncomplicated appendicitis, say they come in the morning, I get them to the operating room, I take out their appendix, and they're discharged that same day. Now, that's not everyone, but that happens quite often. And so then that kind of gets us down the road of thinking about hospital stay costs, further complications, and so forth.
Right. I think that's an important thing. If your length of stay is going to be 8 to 12 hours and you're looking at a day of IV antibiotics, it's a no-brainer. And, many patients, have life issues and they can't stay in the hospital. That's the other thing. And giving them antibiotics for 24 hours is not reasonable. But then again, an oral antibiotic is something they could put up with. So, I think that's something, quality of life and life issues are really important in this choice.
One interesting thing is, we have a home hospital program where we send patients home, and later on that day, they're seen by a PA or an NP or even a hospitalist for some cases. And these might be patients that, look, if you really do want them to be hospitalized for 24 hours, and if your antibiotic regimen requires that, you can have somebody go to their house and poke on their belly a little bit later that day just to make sure that they're not getting worse. And that's definitely an option given the hospital overcrowding that we're all dealing with right now as well.
Mhm. But certain risk factors, we can agree that if you see an appendicolith, you're less likely to give someone that option of antibiotics. Certainly, looking at the recurrence rates and the need for operative intervention, we can see that. Plus, there's another issue too. In older patients that are obese that have a family history of appendiceal cancer, say, it's a consideration maybe not to use a non-operative or antibiotic approach. Would you agree?
So when you look at, the non-operative approach, we know that, in general, cancers and tumors of the appendix are extremely rare. The incidence is anywhere from like 0.15 to zero point 0.9 per 100,000. And we typically see this in individuals between the age of 50 and 55. They affect men and women equally, and they most typically present as appendicitis, right? Or sometimes, a hernia filled with mucin. The idea here is that, even in the CODA study, I think they had 9 patients that underwent appendectomy that had a neoplasm. And so the question is are you willing to potentially miss those cancers? And, I'm not sure I necessarily have the right answer to that right now, but I would just say that if it was my family member, the answer would probably be no, especially considering, the low complications in the majority of patients that undergo a laparoscopic appendectomy. And this kind of, gets us back to, as we look at the results of the study, and maybe we can take just a second to go over those real quick. Look, the antibiotics in the CODA trial were found to be non-inferior to the appendectomy group on a basis of the 30-day EQ5D, right? But when you look at complications, we know that complications were more common in the antibiotic group, right? 8 versus around 3.5 per 100, or an odds ratio of 2.3 nearly. And this appears to be coming primarily from the group with an appendicolith, as Dr. Glatter mentioned. I think the other thing to kind of, keep in the back of our mind is that when you look at the antibiotic group, right, 29% underwent appendectomy by 90 days. And when you look at that specifically for those with an appendicolith, that's about 41%. Very interesting and very different than those who didn't have an appendicolith. So as in everything that we do in medicine, what I would say is that you really have to look at the patient that you're taking care of. And you have to analyze that patient, look at their risk factors for surgery, look at, their presenting signs and symptoms, look at their radiologic, imaging, and all together really make kind of, the best decision that you can based on the evidence that we have for your patient.
And that's a very important point you're making. And I'll let Ali chime in a second on that. But I'd like to also get each of your experience at your institutions. Has there been a buy-in to this approach?
There is not the level of buy-in that you might expect were these data widely accepted. And I'll tell you why. So I had a patient a couple of weeks ago that it was a very questionable early appendicitis, right? He had some tenderness. The CT showed a little bit of stranding, but nothing was enlarged. It was very questionable. So we gave him some IV antibiotics and watched him for a day, and he got better and he went home. I don't actually know that he had appendicitis, but we consulted with our surgeons who were fantastic, and that was the plan we came up with. But I'll tell you, the vast majority of these patients are still going to the operating room, at least here. And I'll give you an anecdote. 6 months ago, my 8-year-old had appendicitis, and it was not a horrible case, right? His belly just started getting tender. The pain just started localizing, and he was in the emergency department and seen by one of the surgical residents. And And my friend, who was the peds surgery attending who took him to the OR, said, look, your son got the appendectomy that a doctor's kid gets, which is a very early, this may or may not have been appendicitis, but we're going to go ahead and take your appendix out so that your mom or dad feels better about it. But it is not standard practice to just treat patients with a real honest to goodness appendicitis, even without an appendicolith, with antibiotics rather than surgery. At least, sorry, at my shop.
No, I would totally agree with Dr. Raja. I mean, I think he's spot on. The majority of these patients are going to the operating room and getting their appendix taken out. Now, there are, certain, situations or scenarios where we may decide not to do that and attempt a course of antibiotics. But in general, I think Dr. Raja nicely described that, and that's what is typically done as well at our shop.
Yeah, certainly someone who's at a high operative risk, an older patient that, just can't withstand an operation, that would be something to me, maybe just antibiotics and observation at that point. Would you agree, Joe?
So it's really interesting. That's exactly how I used to think as well, saying like, listen, like an older patient, a number of different risk factors. And I think there is some role for that. There is some data that's starting to come out. And again, it's not very clear and it's not level 1 evidence yet, but saying that, in those patients, maybe you need to be more aggressive because they really can't tolerate, a perforation, a drain, back and forth, antibiotics. So I think the short answer is we don't know exactly how we should be approaching those, but I think you're right, Dr. Glatter, that you really have to kind of look at those factors. And if, their surgical risk is just beyond what you think is the benefit of taking them and taking out their appendix, then antibiotics would seem like a reasonable option.
Right. A lot of patients that I've seen, they say, what if I get abdominal pain 2 months from now? What if I'm traveling, which, I'm on a vacation, I'm somewhere in a remote part of the world. What do I do? And I think that fear and that anxiety that the pain could come back and they could have appendicitis is a lifestyle issue. A lot of the patients I see, and they've been offered antibiotics, choose no, especially the younger ones and people that are very, mobile and really, travel quite a bit. Obviously not with the pandemic as much, but that's my experience. How would you guys react to that?
Well, I think you're right. I mean, I've had patients that are, either executives or even like students that are going to spend, 6 months abroad, and they come in and they say, well, like, what do you think? Should I get the antibiotics or should I just get my appendix taken out? I'm getting ready to travel. Right. And in those cases, again, like we said, most patients anyways go to the operating room, but in those cases, especially, my recommendation is operative intervention because, the last thing that you want, is to be, in the middle of a, resource poor setting and you don't have access to high quality surgical care. It becomes a lot more complicated at that point.
In all the studies that I've seen, that no one has died. No one has had a ruptured appendix who hasn't had a fecalith. In other words, stable, non-ruptured, acute appendicitis. No one's perforated and no one's died from what my experience in reading this literature. So that's reassuring that if you're somewhere where you can't have your appendix out, it's safe to get antibiotics and then maybe have an interval appendectomy.
I think that's right. I think that, the important thing to remember is that at least in the CODA trial, they excluded patients who came in late and were really sick. So if you were in septic shock, if you had diffuse peritonitis, if you had a walled off abscess, you weren't even in the study. But you're right. If you started off with your general run of the mill appendicitis, you didn't go bad one way or the other after randomization. That's absolutely true.
Right. And I think, going forward, I think, it's an option, certainly as practice changes, as people move to different practice settings, there's going to be differences in, what becomes, quote, standard of care. And it'll be interesting over the next few decades how this evolves.
There's some equity issues here. And so, Dr. Saccone, you were just talking about the fact that you might have these students or these folks who are concerned about a delayed appendectomy and not being in the right resource, the setting with enough resources. But we have, when they come to you, like you said, they say, hey, doc, what do you think I should do? Like, tell me about this. And the way that we sell this one way or the other, right? We can talk about the benefits of not having to deal with a surgery right now, getting some antibiotics and going home, or we can talk about the fact that there's going to be these potential delayed appendectomies as a surprise. But when we're having that shared decision-making conversation that's dependent so much on the subjective way with which we sell one or the other proposition, it inherently leads to at least the concern of inequity, because the way that we sell it to one person may be very different than the way that we sell it to another person. And so I think, obviously, you're all thinking about this as well, but we need to be especially cautious about the way that we speak to patients who might look different or act different about the various options, and give them the real raw data without too much editorialization by ourselves, which I'm definitely prone to at times.
That's absolutely correct. I think that's such an important point, Dr. Raja. We really, I mean, we know health inequity exists all across our country, and all through our different healthcare systems, regardless of whether you're in Baltimore or Boston. And being cognizant of this and like ensuring that there is a lens on everything that we approach in order to kind of achieve a more equitable delivery of healthcare is so critical. So thank you for re-emphasizing that. The other point I was going to make is, we don't have long-term data from this CODA trial, but when you look at like the 5-year follow-up that was done from APAC, essentially 40% ended up needing an appendectomy, over a 5-year period. So it's almost like a coin toss, right? And so I think, as Dr. Glatter, the way you started off the conversation was really nice, in the sense that we probably still need more data. I think we're starting to hone down that maybe, just maybe, there is a certain portion of these patients that present that could be managed non-operatively, safely, with minimal recurrence, but maybe there's a subsegment of that population that still requires operative intervention. So I think time will tell.
Well, it's almost like biliary colic. We see these patients, not quite exactly the same, but it kind of occurred to me, they come in, they're not infective, we manage their pain. Sometimes they get a dose of antibiotics, they go home and they get followed up for operations. But in the same vein, this is almost how I think this is evolving. Would you tend to agree, or do you see any parallels here?
So I think, look, we see a ton of patients with biliary colic. I think that when you look at biliary disease in general, I think the people that are coming in with acute cholecystitis, so they're inflamed, they clearly have an acute gallbladder. Those patients are being admitted and being taken out during that hospital stay. Patients that come in with the second kind of group that I think of are like those with gallstone pancreatitis. In general, those patients should be admitted and have their gallbladder taken out, because we know that 50% of those patients will come back in 4 to 6 weeks with another bout of pancreatitis that's probably even worse. Now, the biliary colic, I think, is a very good example. So these are the non-inflamed gallbladder. I think if their pain is controlled, they can be sent out with minimal pain control, and then return back and follow up in the general surgeon's office for setup for evaluation and potential removal. At 10% of the population have cholelithiasis, and some patients live their entire life without any issues, and some have significant pain that is debilitating. So that's, I think, how I kind of manage those kind of groups of biliary disease, and I think there are some similarities, as you're alluding to.
Yeah, it just kind of struck me, but I think we're kind of a ways from that. It's a thought. I want to just wrap up and maybe get a few pearls from each of you. Ali, if you want to start.
Absolutely. I think there's two main takeaways that I took away from this for my practice in the emergency department. And the first is that we routinely used to tell patients, okay, here, you've been diagnosed with appendicitis. Let me tell you about what the plan is. The plan is going to be that the surgical team will come down and see you, and your surgeon will talk to you about the operation, and we'll get your operation done first thing in the morning if you come in the middle of the night, or maybe later today if you come in the morning. And I think leaving the door open for shared decision-making with the surgical team about antibiotics versus not is going to be key for those of us who practice emergency medicine, simply because of the fact that if we bias our own patients towards surgery, we make it even less likely that even those very appropriate patients for antibiotics, that they'd be willing to accept that. And so I think first of all, we need to not bias our patients one way or the other. But then I think the other thing is that we need to be ready for that, I don't know, 20 to 40% of patients who got treated with antibiotics some time ago, not 5 years in all cases, but within 90 days, as it was in the CODA trial, who come back in and say, actually, you know, that pain that I had about 2 months ago when I got the antibiotics, I'm really worried that might be appendicitis. And there's a good chance that it might be again. So we just need to be aware that those patients, many of them will come back with a repeat appendicitis.
Great, that's awesome. And Jeff?
Yeah, I think those are such great points. And I think we do sometimes tend to, in our mind, have a way about how we think that these should be managed. I think really presenting the evidence in an objective way and tailoring it towards, the patient that you have and giving them kind of the pros and cons is so critical. The only other thing that I would add to what Dr. Raja kind of nicely summarized is just to be considerate of the fact that if you do end up managing, patients with non-operative appendicitis, especially if they're older, you want to consider that they probably, if they're above the age of 50, need a colonoscopy to ensure that there is no obvious, cecal neoplasm. And I think, again, that data is still playing out as to how we're specifically going to approach those type of individuals. But I think that's critical because there are, even if it's a small majority, there are a proportion of patients that will have a neoplasm and the presenting, kind of piece was the appendicitis.
Absolutely. These are great pros. And I want to thank both of you. This is just such an informative discussion. It really helps us go forward because this is one of the most common things all of us see in our everyday practice. Thank you again.
Thanks.
Thanks so much for having us.
That was great.